Good morning, everyone. I believe we haven't heard mostly from the Philippines, and I'm glad that I'm here. So I'm just going to give you an overview of what our current situation is, because you rarely hear from us. So the Philippines is the fastest growing HIV epidemic in the Western Pacific, from 7 persons per day in 2007 to more than to almost 50 per day HIV-infected people in 2023. So if we don't break the cycle, it is estimated that we'll be reaching 360,000 HIV-infected children, HIV-infected people from 2010 to 2030. So the Philippines is an archipelago of more than 7,000 islands, which are broken into 3 categories: Luzon, Visayas, and Mindanao. And with a current population of 114 million, it is devastating that it affects the healthcare system of the country, and HIV being one of the longest healthcare issues in the country is being affected, especially with disparity in healthcare service in both the rural and the urban areas. The seat of the government, which is the National Capital Region or the Metropolitan Manila, is where the number of cases of HIV are being seen. This table shows you that for 5 years, in 2018 to 2022, most of the HIV cases, around 34%, are already diagnosed in advanced HIV disease. And it is important to note that women are less screened compared to men, specifically from over the years. No? And what is most alarming is that the AIDS-related deaths, according to UNAIDS, is around 538%, the change in AIDS-related deaths compared to other countries. Meanwhile, among children with HIV age 0 to 14, comprise only 1% of our total population of patients living with HIV. And NCR, again, being the site of the highest number of cases, is also the place where most children are diagnosed. So overall, the present AHD cases in our country is around 8 out of every 10, and mortality rate is around 13 per 100 pediatric AHD cases. That is really alarming. So what are the reasons for this? One is what is our progress towards the triple elimination campaign. In this table, you will see that in 2019, at least we are progressing from 4% HIV screening among women, among eligible women, from 4% in 2019 to around 21% in 2022. And the bar graph will show you that women are more receptive of is being screened for syphilis and hepatitis B compared to HIV. So one is low maternal HIV screening, which lead us to having AHD. Back in 1998, the Republic of the Philippines issued an administrative order that HIV screening must be done only by a certified HIV counselor amid the limited number. However, in 2018, and this is good news, that HIV screening now can be done even by a trained social worker and in various different settings. However, as mentioned by Dr. Annetson, for 15 years old and above, no parental consent is needed. However, in the guidelines, they are giving us 2 options: the opt-in and the opt-out. And this is probably one of the main problems, that physicians are prone to doing opt-in approach rather than the opt-out. And opt-out testing is mostly done only when the patient already comes in labor and delivery, for any woman who has unknown HIV status. But to be honest, it's not really happening, because in our hospital alone, in my abstract submitted, We had around 42,000 deliveries from 2016 to 2022, and less than 11% only screened for that same time period. So how about the status of ARTs in children? We have so far we have been using efavirenz-based medicine in our setting in the Philippines. We don't have dispersible DTG yet, and the problem really is up to now we have HIV babies born to HIV women who are being given nevirapine paper tubs after birth for prophylaxis because syrup preparations are unavailable. So that is the sad thing. And through the help of Professor Tanya Putanakit and Professor Caroline Foster of NIH, I am now able to procure DTG dispersible for my own patients in the institution through BEB Healthcare, thanks to their help. And I'm sure we all need, like all of you, we all need dolutegravir as first line, but it's not yet approved. The TDG is not yet approved in the FDA, in the Philippine government. So the testing has been differentiated in various settings just so to increase the rate of screening. So we have the facility-based for this, for any clients who visit the following facilities. We have community-based testing, the self-testing, and the index testing. However, the problem lies really with the stigma associated with HIV, so that even women or even, for example, my own patients would talk to them very seriously about getting tested before they even agree to it. So that's really the problem. The stigma in the Philippines is a barrier to promote HIV screening in all, especially among women. So imagine we have 192 treatment hubs as of May 2023, and therefore there is a limited access to HIV services in areas where no hubs exist, especially in rural areas, and especially among healthcare providers who are not aware of what are the signs and symptoms of HIV, and they have to eventually have to refer patients to a hospital around 3 to 4 hour drive just so to be diagnosed, to be treated, and to be cared. How about the budget planning? It is estimated that 94% of the budget should come from our domestic source and 6% from external sources, 43% for prevention, for screening, 8% for testing, and 43% for other treatment expenditure. So where should we get this funding? Where? I don't know how. So what are the most common OIs seen in our children? Philippines is one of the highest country with tuberculosis. Therefore, it is the main OIs, followed by candidiasis, and so on. So we don't have our own guidelines for AHD, but we follow the WHO STOP guidelines. So for our cases, for example, this one is a 16-month-old female from Region 3, delivered in line in clinic. Mother was not screened, has had failure to thrive, and for the in age 6 to 14 months had several admissions, but no screening was done until at the 6th month when she was referred to us, and CD4 and viral load was tested. Tested, and AZT, 3DC, and nevirapine was already started. This is an index case. Another case, however, okay, this was a mortality. So 2 weeks after discharge, the patient died at home. We have a 3-year-old male with recurrent illness, again in a line-in clinic, delivered in line-in clinic. Breastfed was unknown. Mother was a sex worker who died. The father is an employee, fortunately HIV negative, starting at 6 months with recurrent lesions. Again, had several consultations but not screened until at age 2 years old when he was referred, and eventually with viral load of 4 million. As again, AZT, 3TC, ABC was started because of interaction with rifampicin. We do geared towards AZT, 3TC, and ABC as initial treatment. And then we have this 2-year-old female with perianal abscess, 5 admissions, not screened, until referred to us with perianal abscess, with HIV encephalopathy, again with AZT, 3TC, and ABC. We have a 7-year-old male with, imagine, seen by several physicians, 5 physicians with oral discharge. None of them even think of HIV until it was referred to us, and eventually stage 4 already. 6-year-old male, this is not my patient, was discussed only by a colleague who came in with presentation of ITP. Never thought of being HIV until the relatives narrated that the mother died of HIV. And then lastly, we have this 18-year-old male who came in, not my patient, from another region with severe frontal headache, came in as TB meningitis, eventually tested for HIV as an index patient again with mother and sibling also positive for HIV. So what are the learning points? There is a failure to recognize symptoms of HIV even among healthcare physicians, primary caregivers. We have to educate and empower them. We have limited healthcare service delivery in remote areas. We have to decentralize our HIV management. We have to facilitate and ensure adherence of ARTs by helping the families of the members with HIV. And lastly, we have to target prevention campaign to improve PMTCT by an opt-out universal HIV screening to all pregnant women. HIV is everybody's concern. In the Philippines, we don't just have to act, but we have to act better. So our society, because of these alarming events in the country, we will be meeting in December, and we'll be inviting one of the DH officials so that we can be heard. We believe one of the reasons why, to be honest, the children with HIV in the Philippines is not a priority, because mostly the funding is for the MSM and the other key population. So if we don't act now, we will be dealing with more and more children who are undiagnosed and misdiagnosed with other diseases, and then later on coming to us already dying, or already in AHD. So with that, I would like to thank all of you for listening, and specifically I want to thank Professor Tanya Viputanakit for helping me with my presentation. Thank you.